Thank you very much. Good morning, dear colleagues. Welcome to the very early morning session. Today we have four speakers, and first speakers, I would like to invite Dr. Sylvia Veronica Setiawan from Jakarta, Indonesia. Please, Dr.
Thank you, Dr. Abraham, and good morning, everyone. Thank you for coming in these fairly early sessions. I hope we can discuss some, I can share and then we can discuss. Actually, what I'm going to share today is about our experience in our hospital. And the title is Not All Birthmark Fed Equally, Insight into PICO Laser Treatment and Outcome. Dr. Abraham and I work in the same hospital, so sometimes we manage the patients all together. And for disclosures, I have no sponsor or disclosure for this presentation. So the lasers, the brand of the laser is not mentioned at all. So in our hospital, we have, sometimes we have patients with special conditions. Since our hospital is the Army hospital, our hospital is the referral for the all Indonesian Army hospitals. So many of our patients are going to have recruitment for the military. So they need to remove their birthmarks, they need to remove everything not normal in their body due to of the grading of the examinations to go enter in the military recruitments. So we will show you the three patients. The first, the birthmark cases, we were treated with the PICO lasers, wavelength 532 and 1064. And our issue for these patients with these special conditions is patients only have very limited time to treatment. For example, most patients, they came to us and next month, they have to go for the military examinations to go enter into the military. So they have very, very limited time of treatment. And they're unable to come to follow up after laser procedure properly. Normally, we ask patients to come for follow-up 2, 3 weeks or 4 weeks after lasers, but they cannot because they have to go to the military training sessions. And the most important, the first periodic skin type 4 and 5. I think most of us here have the dark skin type, so I think it's quite the same with Asian countries. So far, this is the first case. So this patient have the color event in the central, even and scattered in the edge. This is the birthmark. Then we did the PICO lasers to this patient, and you can see the endpoint is the whitish popping on the skin immediately after lasers. The parameter is 4 millimeter and 4 joule for the 1064 and 2 joules for the 532. And we can see 8 weeks post lasers, hyperpigmentation appeared. And we give the patients topical treatment for treating this PIS is the hydroquinone, retinoic acid, and fluocinolone acetonide, and also sunscreen. And patient came back in 16 weeks, and we can see the hyperpigmentations is decreased, but hypopigmentations is increasing. Then patient never came again, I don't know. And we did this patient only for one laser session only. So that's the issue in the patient like this. They only can come in one times treatment. They cannot repeat the treatment, but they ask us to remove the birthmark perfectly. And this is the second one. Same birthmark, different patients, different locations. These lesions is mostly scattered, so it's like a small getting around together. And we did also PICO lasers with 1064 and 532, the same joule, the same parameter like before patients. And then patient came again for follow-up in 6 weeks, and we can see the hypo and hyperpigmentations happen in the skin. And then, of course, we did treat these patients for the hyperpigmentations, and we can see the results in 10 weeks. Mostly hyperpigmentation happened. Why? Because patients rarely use the topical treatment. So most of our patients special condition like this, they did the treatment, but after that they didn't do any kind of post-procedural treatment. So they think that the lasers can fade it, they pigmentation right away without any other topical treatment. So this is the third case. This is, you can see, mostly scattered, not even, and these patients, fortunately, he came for more longer time compared to the other first two. This patient can follow up until 24 weeks. So we can do more sessions of the laser with these patients. And we can do also 1064 only without 532. So we did the 1064 only with the spot size 4 millimeters with the joule of 3 joule per shooting. 5 sessions, every 3 weeks we did the lasers. And in the 16 weeks, patient came and we can see the clearance is almost 80% clearance of the skin. Yeah, but then after 16 weeks, patient never came again, and we give the patients, of course, the topical treatment and also the sunscreen, and the patient still continue his military field training, and we can see in the week 24, patient come again, and we can see the hyperpigmentation appear again. Yeah, so. This is what we want to show you, that for the pigmentation things, even pico lasers is one of the gold standard for the pigmentations. We can see that without the good post-treatment procedure, without repeating the procedures is almost mission impossible. Yeah, so with the non-standard and proper treatment process, all patients develop pigmentation problems, and the quick treatment with the good result is almost possible. It's almost impossible. So we have to educate our patients very well for the pigmentations, especially in the dark skin patient like us. Yeah, so I think this is our hospital. This is in Jakarta. This is the Army Central Hospital. And I would like to invite you all also to come to our, even in this August in Jakarta, it just if you have time. This is another meeting that we will have in Jakarta in September. Thank you very much for your kind attention.
Yeah. Thank you, Dr. Sylvia, for your nice presentation. So follow-up is really a great problem for in our patients. Like they want everything in single session, so it's very challenging. But the result you showed in single session is quite amazing. Like usually the pigmentation, dermal pigmentation takes multiple sessions to get that result. And to avoid PIH, you can prime the patient earlier with hydroquinone also if as you said, always the compliance is always a challenging thing. Otherwise, if we plan ahead, we can put patient on hydroquinone earlier so that there will be less chances of PIH.
Yeah, so priming is the very ideal conditions. But if patients came to us and asked directly that time he wants to have laser because another month he have to go for the military and examination, that's gonna be so challenging. Yeah.
One of the challenges. Okay, thank you so much.
Thank you so much.
We'll take question at the end after another talk, okay? So I'd like to invite Dr. Manur Kanwal from Pakistan for her talk.
Good morning, everyone. This is Dr. Mahnur Kamal. I am from Pakistan. Today, I will be presenting my study comparing the efficacy of fractional CO2 plus PRP versus microneedling plus PRP for the treatment of acne scars. As acne vulgaris is one of the most common chronic skin conditions, up to 85% of the adolescents and young adults are affected by acne vulgaris. Up to 40 to 50% of the patients develop permanent acne scars. Three type of acne scars that we deal with: ice pick, box scar, and rolling. There are multiple regenerative modalities. Some of them are fractional CO2 laser, microneedling, platelet-rich plasma to treat atrophic acne scars. Fractional CO2 laser stimulates collagen production, remodeling, and promotes skin regeneration via controlled microthermal ablation. As on the other hand, microneedling induces controlled microinjuries and also induces natural collagen synthesis. PRP contains growth factors that enhances tissue repair, healing, and regeneration. The primary objective of the study was to compare the clinical efficacy of fractional CO2 plus PRP versus microneedling plus PRP in patients with atrophic acne scars. Secondary objectives were to assess the safety profile, patient satisfaction, and the best combination therapy among these two modalities. Although both fractional CO2 laser and microneedling are widely used for scar treatment, there is still the limited direct comparative evidence available regarding the effectiveness and efficacy when combined with PRP. The results may help clinicians choose the most effective treatment strategy for atrophic acne scars. The study was prospective split-phase comparative study conducted in the Department of Dermatology. A total of 110 patients were assessed for the eligibility, and 96 patients were enrolled, and almost 58 patients completed the final analysis. Age included was 18 to 45 years. Goodman and Barron grade scar severity was up to EM1 or equal to 1. Fitzpatrick skin type 1 to 4 was included in the study. Right side of the face was treated with fractional CO2 plus PRP, and left side of the face was treated with microneedling plus PRP. There were three treatment sessions performed, 4 weeks apart, and PRP injected intradermally at the both treatment sites. Baseline assessment was done by demographic data, Goodman and Barron grading scar severity scale, and photographs. The primary outcome was improvement in acne scar severity measured by the Goodman and Barron grading scale. Secondary outcome included patient satisfaction assessed by the visual analog scale, quality of life score, and adverse effects monitoring and safety profile. This is one of my patients, 24-year-old male, came in with atrophic acne scars. Left side was treated with microneedling plus PRP, and right side was treated with fractional CO2 plus PRP. The photographs are taken at the baseline and 3 months follow-up. The side treated with fractional CO2 laser plus PRP demonstrated a more noticeable clinical response compared with the microneedling plus PRP side, although microneedling plus PRP also gave us moderate scar improvement. Among 58 patients, the gender distribution was almost equal, 51.7% female and 48.3% male. Mean age was 28.4 years, between 18 to 40 years. And as this study was conducted in Pakistan, then most common skin type belongs to Fitzpatrick type 2 to 4. Baseline scar severity was comparable between both treatment groups with no statistically significance different. The scar severity at baseline and the scar severity at 3 months. The scar severity at baseline was comparable, and with no significant difference between groups. The p-value was 0.670. After 3 months, the fractional CO2 with PRP side showed marked greater improvement, with most patients achieving macular scars and none remaining with the moderate scars. In contrast, the microneedling with PRP side had a higher proportion of mild and moderate scars. At baseline, the Goodman and Barron's grading was comparable between both the groups. Median grade was 3. And after 3 months, the median grade improved to 1 from 3 on the fractional CO2 laser plus PRP side, and from 3 to 2 in microneedling plus PRP side. The lesser the number shows the more improvement in the acne scars. And when it comes to the quality of life score, a patient treated with fractional CO2 plus PRP demonstrated scores 11 and also goes same. The lesser the score, it shows that more significant improvement in the quality of life, patient reflecting the positive psychological impact of improved scar appearance. And more than 50% of scar reduction was seen in the fractional CO2 laser with PRP group, with 89.7% achieving this outcome, compared to 32.8% in the microneedling with PRP group. Self-rated patient satisfaction was also higher in fractional CO2 plus PRP group, as 94.9% of the patients were either satisfied or very satisfied, with no patients reporting dissatisfaction. In contrast, the microneedling plus PRP group side showed higher rates of dissatisfaction. When it comes to the complication, pain was the most common adverse effects among both the groups. Post-inflammatory hyperpigmentation was common in fractional CO2 plus PRP side, and on the other hand, bruises and hematoma were more observed in the microneedling plus PRP side. Overall, both treatments were well tolerated with a low complication rate. Our findings were also consistent with the previous studies demonstrating the effectiveness of fractional CO2 laser and the synergistic role of PRP. Studies by Asif, Fabricini, and Lee reported significant scar improvement, enhanced wound healing with fractional CO2 plus PRP. Similarly, our study confirmed superior efficacy, patient satisfaction, and quality of life outcomes with this combination. The study has several strengths. This was a split phase design. Each patient act as their own control, minimizing the confounding variables. Blinded assessment was done to reduce the observer bias. Additionally, standardized treatment protocols improved reproducibility. Despite encouraging results, several limitations should be acknowledged. The sample size was relatively small, and follow-up was limited to 3 months. The study included only Fitzpatrick type 2 to 4, and site allocation was not randomized. Future multi-center randomized control trials with longer follow-ups are needed. As I move forward, conclude my study, the fractional CO2 laser combined with PRP demonstrated significantly superior outcomes, as 89.7% patient showed 50%, more than 50% scar improvement. There was better quality of life in fractional CO2 plus PRP group. So both treatments were safe. However, fractional CO2 plus PRP emerged as the more effective treatment option for atrophic acne scars. Recommendation would be that based on their findings, fractional CO2 laser combined with PRP should be considered a preferred treatment options for patients with atrophic acne scars. Why? It has superior efficacy, higher satisfaction, better quality of life, and acceptable safety. Thank you so much, everyone, for your attention and time.
Thank you so much. Very nice presentation. Yeah, we know that the acne scar is very challenging. Now we are open for the 2 speakers. Open discussion, please. For 2 speakers, Dr. Sylvia and Dr. Kanwal.
Yeah.
If you have any questions, you can ask to the speakers. The presenters are well ahead of time. That's great. We have enough time for questions.
Yes, please.
When you mention fraction CO2 and PRP, do you combine, meaning like you do the CO2 first and then you do the PRP in the same session, or you mean like do
In the same session.
Okay.
First, PRP was injected intradermally in the scar area, the area that I needed to be treated, and then fractional CO2 was performed in the same session. Both the treatment were performed in the same session.
So you do microneedling with PRP and then the CO2?
Yeah, because they were in the same patients. It was split phase trial. One side, the left side was treated with microneedling plus PRP, and the right side was treated with fractional CO2 plus PRP. All of these sessions in one, all of the treatments in one session.
Okay, but not one area with both devices, meaning like microneedling PRP and then CO2 on top?
No.
No.
No,
Okay.
no, no, no.
I understand.
No, 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 no.
Thank you.
Any other question? Yes, please.
Can I from here? Is there any contraindication regarding previous intake of isotretinoin in these patients?
Yes, there was this exclusion criteria. Those patients were not included in the study who were taking the isotretinoin or had active acne going on. So yeah.
So I would like to add on this. Please continue.
The orally, and is there any other indication for topical application of isotretinoin?
Indication?
Contraindication.
Contraindication, but both the patients either were on topical, either were on oral, were not included in the study.
So either topical or orally,
Either, both ways,
yes, both,
were not included in the study.
and cannot be included in the study.
No, this was exclusion criteria. Because isotretinoin is keratolytic. It enhances the skin sensitivity, and it also increases the photosensitivity of the skin. So this was the exclusion criteria. Those patients were either on topical treatment or oral treatment were not included in the study.
Okay, thank you.
So regarding isotretinoin, I would like to add something. The concept has changed, okay? These days, previously they used to tell that after completion of isotretinoin for 6 months, then only you start treatment for the scar. But these days, like if you start procedure early, even when the patient is on isotretinoin, for the superficial, not for the fully ablative procedures,
Exactly.
but for superficial to medium type of procedures, then the results are found to be even better when the patient is on isotretinoin. So I'd like to add that.
Okay.
Thank you.
Thank you, everyone.
The next, I would like to invite the next speaker, Dr. Seo Yung Seok. Please.
Good morning, everyone. Thank you for the invitation to this session. My name is Young Seok from Korea. Today's my talk, Optimized Cooling Control Enhanced Thermal Remodeling in Monopolar Radio Frequency in a Porcine study. Let us begin with why the cooling algorithm is important. As we best know, monopolar radio frequency includes induced thermal heating to promote collagen remodeling, skin tightening, and extracellular matrix reorganization. Especially, a key challenge is achieving sufficient thermal heating while minimizing epidermal injury. To date, the impact of the cooling sequence design itself remains largely unexplored. Therefore, our study hypothesis is that the design of the cooling algorithm directly influences thermal behavior and the subsequent thermal remodeling outcomes. This is a materials and method. In the animal model, we utilize the 3 micropeaks within animal comparative study. As you can see from the table, the operating frequency was set 6.78 MHz. For the treatment groups, site A and B were irradiated using the G mode, which features the condensed cooling sequence. Site C and D were irradiated using the X mode, which features an expanded cooling sequence. We evaluated the energy levels 4.5 and 8. Our evaluations included some surface thermography, intradermal temperature measurement, cross-skin observation, serum chemistry, histology, as well as collagen and elastic fiber remodeling. We need to know the difference in cooling algorithm between G mode and X mode G mode utilizes the condensed cooling sequence with limited cooling events. In this mode, cooling is applied only before and between selected RF shots. X mode provides an expanded cooling sequence. It introduces additional pre-cooling, more inter-shot cooling events, and additional post-cooling. This results in the great cooling frequency, longer accumulate cooling duration, and more comprehensive epidermal protection. This is a result of the thermal response. Based on our surface thermography, we observed the localized increase in skin temperature immediately after treatment. This temperature elevation occurred across both mode and both energy levels. You can see a picture of the MBTC staining results with no epidermal necrosis. And more intradermal temperature at the 2 millimeter depths are measured exactly. You can see that both modes achieve the effective dermal heating. These are ultrasound images of intradermal temperature monitoring measurements performed at the 2 millimeter and 4 millimeter depths. You can see a rapid temperature increasing immediately after RF delivery and a gradual return toward the baseline. The key finding here is that both G mode and X mode successfully produced controlled surface heating and effective intradermal thermal engagement. This is the result of the safety evaluation. Both cooling strategies demonstrate the excellent safety during our gross observation from the day 0 to day 30. We found no clinically significant, such as persistent erythema, ulceration, scarring, or severe edema. Histological assessment using MBTC staining showed no epidermal necrosis, and H&E staining demonstrated preserved skin architectures. Furthermore, serum chemistry evaluation showed only minor time-dependent fluctuations observed and no evidence of the systemic toxicity. This is the result of the collagen remodeling. Through Mason's trichrome analysis, we confirmed that the collagen area fraction increased over time in all treated group. Especially X mode consistently produced great collagen remodeling than G mode. Similarly, we looked at elastic fiber remodeling. Our elastic fiber analysis revealed significant increase during the late phase of the study, which were most pronounced at day 15 and day 30. These results suggest that the enhanced cooling may promote broader ECM remodeling, particularly under higher energy conditions. We also performed an immunohistochemistry analysis to track collagen type 1 expression. You can see that the picture of the collagen type 1 expression increases over time in all treatment groups. Interestingly, the effect of the cooling strategy on collagen type 1 expression appears to depend on the delivery energy level, suggesting a mode by energy interaction in the remodeling process. In conclusion, both modes achieved controlled thermal heating and demonstrated a favorable safety profile. ECM remodeling occurred predominantly during the late phase between day 15 and day 30. Most important, X mode constantly enhanced collagen remodeling, providing that the cooling algorithm design significantly influences treatment outcomes. Our final take-home message is this: cooling is not merely a protective feature for the epidermis. It is a clinical treatment parameter that can directly influence remodeling efficacy in monopolar RF systems. The expanded cooling strategy, or X mode, produced superior thermal collagen remodeling compared with the condensed cooling strategy of G mode, all while maintaining a highly favorable safety profile. Finally, I would like to express my gratitude to Korea Medical Laser Clinical Trial Center. This research was supported from Korea government. Thank you very much for your time. If you have any questions, cut me. Thank you.
Yeah, thank you, Dr. Seo, for your excellent presentation. And is this model already available for commercial purpose, or just you are inventing this?
Yeah, I know the scientific process. Yeah,
It's only in the scientific process.
yeah, I know.
Not still in the market, right? So maybe in future, if we get this device, it will be good for us. Thank you so much.
Thank you very much.
So we'll invite question after this another speaker, okay? Yeah, please, you can go.
Yeah, thank you.
So another speaker is Gorskaya Antonia. Her talk is on EBD to nodules, trigger or treatment. Welcome her on stage.
Good morning, everyone. Good morning, dear moderators. It's a big honor to stay here today, and let me share with you my experience is in treatment of nodules, because now we'll use a lot of collagen stimulators like PLA or hydroxyapatite, etc. And sometimes we can get from our patients so impressive pictures. You see the video or something like that, like edema, and sometimes this edema can be impressive for both for doctor and for patients. But of course, sometimes such events can appear after incorrect technique. It depends on the layer, it depends on the technique, but in the same time, it's a very horrible situation, in my opinion, for both for patients, because such nodules can last for years, and for doctor, because we have no clear pipeline how we can to treat it, and usually we have no direct antidote for such products. And now we distinguish two types of nodules. It could be inflammatory and could be non-inflammatory. And our strategy in treatment of such complications should be very different. If we get inflammatory nodules, usually we use antibacterial therapy, but if we get non-inflammatory, it's a very difficult situation for us. And of course, all of them have their own features. For example, usually inflammatory nodules we can get in the first period after injection, in the first few months, but non-inflammatory typically presents maybe in years, and it could present immediately. But if we speak about inflammatory nodules, usually we can get it in few, maybe 4 weeks, maybe 6 weeks, and usually it can be, could be painful and redness, etc. But if you speak about non-inflammatory nodules, sorry for mistake on this slide, usually it can presentation in 60 months. Can you imagine? Sorry. Can you imagine we inject, for example, polylactic acid, and after 5 years we can get a call from our patients with a problem. And why it so happened? One of the reasons is late inflammatory reaction, and now we know that 1% of our patients can give these complications in any other treatment. We can make right injection, take good products, but we can get this complication. And in this case, we can take and pay attention key factor of late inflammation reaction, such as subclinical inflammation, especially like mouse, chronic infection, etc. Of course, we have taken account biodegradation time of the product, because now we have a lot of different type of products. We have a lot of polylactic acid, and they are all different. I work a lot with such products, and we know that the biodegradation time depends on the size of the molecular, weight of the molecular, and of course it depends on a lot of factors. And now we know that different polylactic products have different outside effect and biodegradation time. And the main point when we speak about biodegradation time, that biodegradation time influence on the inflammation process. And if the biodegradation time of the product more than 1 year, the inflammation process could last till few years. And of course, it's one of the key factors of complications. And one of the important key factors of late immune reaction for sure is the immune system and bacterial infection. But if we get such a situation, what we can do? Now we can use a different type of treatment methods. And of course, in my opinion, we have to turn to EBD method, because it's one of the perspective methods to treat such complications too. And we have to keep in mind that most of nodules can't resolve themselves, but we are exploring the possibility of using lasers and EBD now, and we can pay attention to some key successful factor using EBD. For sure, first of all, EBD has the potential to destroy connective tissue, such as, for example, fractional IF, monopolar IF. Sometimes we can use HIFU technology, etc., etc. Of course, we can use lasers, but we have to keep in mind the second key successful factor. Our EBD factor have to reach the place where the nodules is present. And that's why usually we can use such methods like fractional IF microneedling, monopolar IF, and of course fractional laser, which can reach, for example, 4 millimeters depth. And here reports about lip granulomas. As example, let me share with you statistic. You see that more than 60% of nodules can resolve ourselves with any treatment. Usually it can happen in first 6 months. And then we can, of course, use some injection of corticosteroids and some EBD. Let me share with you some my clinical cases. It's here you see the complications. It's my patients, and the nodules appears after 2 years after injection, and we do nothing. And you see it's red, and patient feel pain when I make palpation, but in 4 weeks it's disappeared ourselves, because my patients have got COVID, and after COVID we can get such complication. But another story, sometimes some of us can use such mechanical methods like you see on the slides from Korean doctor publication, when doctors use curettage. Another clinical case which was reported in PubMed, here doctors use bipolar IF devices, and you see how nice result we can get. And I know that I have to be in timing. It's a few last clinical cases, and it's my patients too. You see the granuloma after PLA injection, and it's very difficult areas to treat, and we take here fractional IF, needle fractional IF, and it's very we can get very nice result, but we can get very we should to be very accurate. We have to reach this nodule. To do it, we have to fix all tissues and use a fractional needle to depths maybe 2 millimeters here, but usually we don't use such depth for this area, but it's a specific case. And you see then in 4 weeks we get nice results. There is no any nodules here. And it's one more clinical cases, and sometimes we have to think a lot before to take in our hands, for example, corticosteroids. On the first slides you see how horrible atrophy we can get after injection of corticosteroid, and then we have to use a lot of skills to treat the result of our treatment. And my first questions was when we take EBD, is it cure or poison? And in the first part of my report I show you how we can use energy-based devices to treat different type of nodules, but sometimes it should be the reason. And you see the clinical cases when doctor use a combination of HIFU technology and polylactic acid injection in one session, and you see the result. And sometimes it can happen because when we use stimulators, we have to take into account the patients, because we don't know exactly what how is the immune system of the patients can react. We have taken account the product which we'll inject and how many energy we will promote to this patient with our procedure. And in conclusion, I want to share with you some ideas. First of all, we have to use safety protocols of our injection. In my opinion, if you want to combine two factors, energy-based devices and, for example, collagen stimulator, we can divide it in two different procedures with break maybe 4, maybe 8 weeks, not less. And of course, in my opinion, energy-based devices, different type of them, are very perspective for the treatment of nodules and such complication. Thank you for your attention.
Great presentation, Dr. Gorskaya. Thank you very much. 1 minute left for discussion. Sorry, we can discuss until
We have
10.
enough time for discussion.
Before doing this type of procedural, is there any necessary to do FNSC or biopsy of the nodule?
Speaker, please.
Do you feel any necessity to do fine needle aspiration cytology or biopsy of the nodule?
Please repeat what to do.
To do fine needle aspiration cytology or biopsy for histopathological examination of the nodule.
Oh, thank you so much for your questions. For sure, we can say that it's granuloma only after histological inspection, only after we take biopsy. And in my opinion, for sure we can do it, but when we speak about patient, usually we speak about face. And not a lot of patients are ready to take biopsy from the face because they are scared of scars. And first of all, in my opinion, we have to understand what nodules we get. If we don't see the nodules and we can just palpate it, in my opinion, we have to do nothing because it's a very common situation, and as we know from statistics, usually such nodules can disappear outside in months. But if we, for example, have nodules visible, not painful, visible, usually, and we try to do something, and don't get any result. In this case, yes, we can take biopsy, but for normal situation, in my opinion, it's not necessary.
I have two questions for you. Thank you for your presentation. The first is you are using a 12-pin tip, right? Will it be better if you just use a single pin, number one? The second question is, what do you think is the mechanism of action of using RF? Is it to break up the nodules, or what do you think is the mechanism of action?
For sure, you can use one single needle. The idea that we have to destroy this tissue, and that's all. Usually, we see nothing just immediately after our session, but from week to week, the nodules start to disappear and become less. It's look like this usually, but the first result we can evaluate maybe in 1 or 2 weeks after session. But in my opinion, nodules needs time. We should not be rush, and if we take, for example, fractional IF and make first treatment, then we have to wait maybe 1 month, maybe 2 months, and then repeat. It's just because it's a lot of connective tissue. Sometimes it's not granuloma, sometimes it's hyperstimulation. And what it's mean? What's mean hyperstimulation? It's mean that we get a lot of connective tissue in this place, and our goal to destroy. When we use a fractional IF, we get a high temperature in this place, and we destroy this connective tissue, and that's all. Yes, but we can take less energy, and we can take less pulse duration. In this case, the destroy is much more than stimulation. And when it's very good questions. When we use fractional needle IF to treat granulomas, we have to take maybe more power but less pulse duration. In this case, we can get more mechanical destroy of the tissue and less stimulation. It depends on our parameters, because stimulation, the level of our collagen stimulation depends mostly of our pulse duration of fractional needle IF technology.
Any other questions? Any other questions? So one thing I'd like to highlight is medical legal aspect is also very important. So in the consent form also you need to mention about these rare complications well ahead. so that just in case it happens, you will be on safer side, and you need to reassure the patient like it will take time, no? So patient will be very anxious, and you need to have comforting words to the patient and have a good regular follow-up with these kind of patients.